Thank you to Dr. Kinga Gizek-Oleshniak and the WFLD for this invitation to speak. My lecture is Minimizing Peri-implant Complications through Optimal Management of the Oral Microbiome. So let's start with what is periodontal disease? Well, periodontal disease is a microbially mediated inflammatory disease, and it affects the tissues around the teeth, leading to bone and tissue loss. It's caused by many different types of bacteria working together, creating what we know as a dysbiosis, where they overgrow and create bacteria which are able to cause disease in the body by virulence factors and dysregulation of immune response, and disrupts tissue homeostasis. And we know that there's an increased risk of other chronic inflammatory diseases like diabetes mellitus, cardiovascular diseases, pregnancy outcomes, respiratory infections, and rheumatoid arthritis. And so what is peri-implant disease? Well, similarly to periodontal disease, it's an inflammatory process, and it's caused predominantly by bacterial microbiofilms on the surface of the implant. We have implant mucositis, which can be present in up to 80% of implants, but it tends to be a reversible gingival inflammation where there can be redness, swelling, bleeding of the soft tissues around an implant. Or you can have peri-implantitis, which may be up to 30% of some implants. But this is very much a dysregulated inflammation where you have tissue damage around an implant and loss of the supporting bone. So if we look at the rate and progression of peri-implant disease, we find that peri-implant mucositis is a precursor to peri-implantitis, much like gingivitis is for periodontitis. It's a continuum, but it isn't linear. There's periods where it's very much accelerated, but in the majority of cases, onset occurs within about 3 years of function. No current effective treatment for peri-implantitis exists, although one of the preventive measures is to actually manage peri-implant mucositis well so that it doesn't continue on to peri-implantitis. In the majority of implant cases, some 52% of implants will have complications at 2 years, and some 66% will have peri-implant complications at 3 years. So it's generally something that happens fairly early on in the disease process. So early detection and management of peri-implant mucositis is key. So risk factors for peri-implant disease. Well, currently for peri-implant disease anyway, it's inconclusive that smoking and diabetes are related. And there's limited evidence for submucosal cement, keratinized mucosa, implant position, occlusal factors, and other systemic conditions, although it's highly associated. But there's certainly strong evidence for poor plaque control, irregular maintenance therapy, and a past history of chronic periodontal disease. So anyone that has placed implants for a long period of time will have cases like this, where we'll see bone loss around implants, where we'll see redness, swelling, poor plaque control. So it's all about how to try and pick this up as early as possible. So we have our tools. We measure pocket depths, we measure clinical attachment loss. We see if there's bleeding when we probe into the pockets, if the teeth are moving, if there's plaque and calculus around the implants. And we can also use dental imaging. There's very advanced imaging nowadays. We can use cone beams. We can use other types of imaging to see what kind of loss happens around implants. And we're getting very good at it. We can have AI also work around the radiographs and give us information about the bone loss and the pattern of loss. But very much with all of this is looking at the history of disease. So as with periodontitis, we look at staging and grading. So staging measures the severity and the extent of the distribution of the damage. And then grading attempts to look at the rate of disease progression and what kind of risk factors. So unfortunately, staging is very much looking at what has already been damaged. And grading is very, very difficult to predict, and as such we haven't been able to develop anything more than risk factors. So the critical challenge for clinicians is to try and identify the patients that have that elevated risk and the ones that are going to progress on to more advanced disease. So we've tried to develop biomarkers to help us in this, and there's biomarkers for the host and there's biomarkers for the various microbes. But as such, there's no FDA approved saliva diagnostic test as yet, or chairside test for periodontal disease. And all of these various biomarkers, they take time to process and to do your measurement. There's of course many benefits to biomarkers and many qualities which would make an ideal biomarker, and we can talk about these for a very long period of time. But essentially, at the moment, they take a long period of time, and they're difficult and expensive. So the current understanding with periodontal disease, and it's very similar with peri-implant disease as well. So we start with a patient that is periodontally healthy. They may develop into a patient with gingivitis, but that process seems to be reversible, and a patient can progress from health into gingivitis and back again. But once a gingivitis patient progresses into periodontitis, then it does not seem that they're able to become a periodontally healthy patient again. All we have is a periodontal patient that has stable health, or they become gingivally inflamed again, or have periods of recurrent periodontitis. And if it very much follows peri-implant health, peri-implant mucositis, and peri-implantitis. So one of the problems that we have is that it's hard to identify what is healthy in the oral microbiome. And studies have shown that when they do taxonomic composition of periodontally healthy individuals, they find that it is difficult to actually classify what is periodontally healthy, because what we thought was healthy is actually patients that have already experienced dysbiosis. And they say that oral microbiome dysbiosis can precede the clinical signs of disease by many months or even years. So the absence of periodontal pockets does not necessarily mean good periodontal health. And so the image of what is considered to be a healthy oral microbiome is not a very clear picture and can be distorted. So in the oral microbiome, we have a diverse bacterial community which has well over 700 bacteria species. There usually are 200 to 300 types of species in the mouth. Of the 775 known species, we have some 13% that are still unnamed, and then we have some 30% which are uncultivated or uncultivatable. And we can use processes like 16S ribosomal RNA metabarcoding or whole metagenome shotgun sequencing or metatranscriptomics to explore the diversity of the bacteria and the oral microbes, even when they're unculturable. And so we can identify that there are lots, even though we can't culture them easily. So in the oral microbiome, we have a core and a variable microbiome. We have what we can consider commensals, which are compatible with health. And then we have opportunistic. So we have the pathogenic bacteria, viruses, parasites, and so on, which can cause disease. And the majority of bacteria in the mouth, they exist as a biofilm. So, but in health, there is a homeostasis, and the bacteria that are there can prevent the overgrowth of pathogenic bacteria. But what happens is the bacteria is changing every day because we're exposed to them on a daily basis. We may breathe them in, take them in through the air, take them in through our food. And so there's very much this intake of all of these microbes. Very much it's predominantly bacterial and less of the others. But on a daily basis, we're ingesting 1 million to 1 billion microbial colony-forming units every day, depending on the type of diet that we eat. And these bacteria, they exist in different parts of the mouth and in different concentrations, depending on their preference. But everything that we put into the mouth, like dentures and implants, they again become additional surfaces that can form biofilms and become problematic. So let's have a look at what biofilm is.
Once tooth enamel is cleaned, salivary glycoproteins quickly deposit on the tooth surface, allowing pioneer species of fast-growing bacteria in the saliva to bind, recolonize, and quickly begin reforming the biofilm. Then other species attach and continue developing a thicker biofilm. The bacteria multiply, producing polymers, and even communicate with each other, resulting in a complex three-dimensional biofilm. The early colonizers are beneficial, good bacteria. However, they can create an environment for slower-growing, pathogenic, bad bacteria to start to thrive. Inadequate oral hygiene allows for a thicker, more mature, and complex pathogenic biofilm to develop, which can lead to an imbalance between the good and bad bacteria in the oral microbiome, a term called dysbiosis. Here, pathogenic bacteria release toxins and enzymes that trigger an inflammatory response in the gingival tissues.
So in a mature biofilm, the bacteria can actually start to share genes like antibiotic resistance, and then the biofilm can clump and shed, and so you can have individual bacteria going into the bloodstream or to other parts of the body and possibly cause other chronic infectious problems. So here's an example of the biofilm on a tongue cell, and we can see that the spatial organization is quite complex, and this is very difficult, expensive, and time-consuming to analyze. But you get a sense of how complex and the different interactions between the bacteria at different levels and at different places in the mouth. So as we said, this is the current understanding of the bacteria, where we have different types of bacteria working together, causing a dysbiosis, and you're having clusters of bacteria in different parts of the mouth, causing ecological change, and then changes to the immune system and homeostasis of the cells. So in a case where you have some disorganized bacteria, it has little impact on the immune system. But as they start to work together and share resources, then the body has to combat these bacteria. And then when they start to be colonized by some keystone pathogens, that's when the bacteria can overgrow the pathobionts, which cause disease. They overgrow, they disrupt tissue homeostasis, and then we have dysregulation of the protective immune system, and we have overgrowth. So if you imagine that the bone and the pockets around the tooth are like the walls, then it's important that we have some sort of protection for the system, or some way to monitor these protective areas. Otherwise, the first thing that's going to happen is we're going to have damage to these areas, and it may already be too late. But luckily there are some biomarkers of pathogenic biofilm. So this paper by Kais and Rams, it shows that in analysis of a microbial biofilm, that spirochetes and crevicular leukocytes can act as simplified biomarkers of pathogenic biofilm. And it's a way that we can assess the risk of an individual for having other problems. And this happened because we have early colonizers, middle and late colonizers, and they happen to be of different types. So for instance, we have early streptococci, actinomyces that will colonize. Later on, we have Prevotella, Fusobacterium, and then later on we have things like AA and PG, T. forsythia, Treponema denticola. And I want you to pay particular attention to the Treponema denticola. So when we look at different shapes of bacteria, we can see there's many different types. There's cocci, there's bacilli, and there's others. But the one that is Treponema, they're in a class called spirochetes, and they have this particular shape. And the spirochetes have three major genera which cause disease. There's the Treponema, which can cause Treponema pallidum, causes syphilis, and Treponema denticola is what causes periodontitis and early implant failure. We have the Borrelia, which causes Lyme disease and relapsing fever. And we have Leptospira, which causes leptospirosis. And then possibly there's some link with Alzheimer's and Parkinson's, that's still undetermined as yet. But the problem is that looking at a patient like this, and even observing the clinical signs, seeing if there's any pocketing or bleeding, that doesn't tell us a lot about what is in the biofilm. If we disclose the biofilm, we can see that perhaps we know which may have some pathobionts within the biofilm, but we're not sure. It's only when we really have a close look and actually see the bacteria that are within the sample that we can really determine what is in there and which is healthy. So one of the ways that we can do that is with a phase contrast microscope and a large screen so that the patient can see. And let's have a look at what healthy is. So this is healthy, and it looks like a still image, but this is actually a video. But the bacteria are not moving very much. There isn't very much to see there. Contrast that with an area of dysbiosis, and when I start the video, you can see that everything is moving. It's wiggling. The bacteria are interacting with each other. There's white blood cells, and there's much more movement on the screen, and there's much more than we previously saw in health. So the way that we can do this is we take a subgingival sample from the tooth. We place it onto a glass slide with a mounting medium, and then we put a cover slip on top and squash that down, and then we can have a look. And so we can have a look at this child with swollen tonsils and poor oral hygiene. And we can see the bacteria are moving very vigorously. And so this was a case of antibiotics for this child, and that helped him to get rid of the really bad breath that he had. This is a 16-year-old child, again with poor oral hygiene, and we can see that he has bleeding gums. There's no pocketing, but he has an extremely dysbiotic biofilm with very active spirochetes. Here is a patient that came to us regularly and saw us every 6 months for his routine hygiene visits, and he expressed that he had some tooth sensitivity and a little bit of a toothache. So when we looked at his biofilm, we could see an immense amount of activity and a very heavy biofilm, very, very active. This is a patient that came to us and we had to extract a tooth, and 13 months after, he still has this incredibly active biofilm with plenty of spirochetes, and he's wanting an implant. And I'm just not ready to give him that implant just yet. This is a patient with caries and gum problems, and you can see it's a very thick, heavy biofilm again, with white blood cells, and there's many small bacteria there. This is a mother with a high caries rate, and her children have a lot of caries as well. You can see that it's incredibly active, a lot of white blood cells again. So, why do we use lasers in periodontal treatment? We know that conventional mechanical debridement is insufficient to prevent recolonisation. They just don't. We don't either remove enough, or they're not killed in sufficient numbers to prevent recolonisation. So by using the lasers, we allow deep and lasting decontamination. We inactivate the bacterial toxins, both on the implant surfaces and in the periodontal tissues. And then we have faster healing through photobiomodulation, which promotes fibroblast and osteoblast activity. We have increased cell signaling and collagen production through use of the laser. And we have different techniques that we can use depending on the type of infection that we have. We can just reduce it with laser bacterial reduction. We can use photodynamic therapy, photothermal therapy, or laser-assisted periodontal or peri-implant therapy with multiple lasers available to us. But we can also do more. There are antibacterial agents that we can use. This is one of them. This is ozone. And we think of this mostly in the upper atmosphere, but when oxygen combines with lightning or ultraviolet rays, we get ozone. And ozone has some very interesting properties. It's available in gaseous and aqueous form. It's used around the world for water purification because it's antibacterial, antiviral, antifungal, but it also has anti-inflammatory properties and analgesic properties. It stimulates the cellular and humoral immune systems and can actually enhance wound healing. It does so because the ozone breaks down to a hydroxyl group, which is a powerful oxidizer, but also very unstable and has a short half-life. But again, that can be very useful for us. So in the dental office, we can use it in many different ways. We can use it in our dental chair. We can use it to prevent biofilms forming in the dental water lines. We can use it when we're in our handpieces, so that we're actually spraying ozonated water and decontaminating the tooth as we're preparing it. We can use it as a pre-operative rinse. We can use it in our equipment that when we're doing our cleans. We can certainly use it in our lasers certainly with the erbiums. We can use it, and it's available to us, on demand. We can prepare it either from a tap or from a central disinfection unit, but we can now also have it as a tumbler like this that the patient can take home and the patient can use at home. So using it with a system like this, we have the benefits not only of the powder and water being used to remove the biofilm, but we also can expose the patient to a strong concentration for a long period of time with ozone, which again is going to help reduce the bacteria that's in the mouth, but it's also antifungal. If we're using it with the laser, again, we can get into those deep periodontal pockets, peri-implant pockets. We have the ozone being flushed deep into those pockets and really able to make use of its oxidative properties. But during COVID, for instance, there was the period of time when I wasn't able to do any cleans, and so a patient came to us and said that they just had a heart attack. They had 3 stents placed. We checked their oral biofilm, and it was very, very high. You can see those clusters of spirochetes there. So gave the patient a home ozone unit to use, and after 3 months of rinsing with ozonated water, a lot less spirochetes, a lot less bacteria as a whole within his biofilm. And after that, we were able to get him in and do some therapy for him. So let's look at some case studies. This is an implant case for a 26-year-old. Very straightforward implant in a healed site. We placed this implant 2 years ago. We placed the healing cap on, and everything was fine at the time of placement. But 2 months later, we found that the implant was mobile. We had suppuration. We had bleeding. The implant was not in a good way. And we had only just started using the microscope. So we found that they had a very high spirochete count. They had this infection around this implant, bleeding, and this This is likely the reason why. So we did some guided biofilm therapy, we used laser periodontal therapy, we asked them to brush with a tooth serum, and so, you know, in only 2 months we were able to reduce the spirochete count, reduce the amount of bacteria that was in the biofilm, and by September they showed no further signs of inflammation, no pocketing, and a very stable biofilm, and we were able to restore this implant by the end of the year. This was a patient that was referred to us for implant placement. A bone graft was placed, and at the time we did guided biofilm therapy. You can see he had imperfect hygiene, and this was his biofilm. So we had a moderate bacterial load, but he did have spirochetes. And so with a history of periodontal disease, that wasn't completely eliminated, even though he's referred to us, and he wasn't quite ready for his implant at that stage. So we asked him to do daily rinsing with ozone after guided biofilm therapy, and we can see that there's a much reduced bacterial load, very low motility of the bacteria, and there were no further visible spirochetes. So 7 months after the graft, the bone was healed, and we were able to place the implant. And again, you can see continues to have very low bacterial count with low motility and no visible spirochetes. We went further with this case, and we sampled him, and you can see that he did have he had TF and TD, FN, and of course he was a periodontal patient, so you'd expect it to be some of these bacteria, but we were able to keep these bacterial numbers down at a level where we can prevent disease. The patient went away, unfortunately didn't come back to us for a little while, and you can see he didn't have perfect hygiene, and there was some bleeding after we completed his clean. But again, when we sampled it, even with that imperfect hygiene, he still had no visible spirochetes, low bacterial load and motility. So thankfully he was stable, but we would like to see him, of course, much more regularly and prevent any future complications with his implant. This is a periodontal case, quite severe generalized bone loss and some very localized bone loss in this 59-year-old female. This is her biofilm, very, very active, very, very severe spirochetosis, very high motility. And by March of this year, this is what her biofilm looked like after home rinsing with ozone, and several rounds of guided biofilm therapy and 1 round of laser therapy. There's no longer any visible spirochetes. So in June, this is what she looked like after her first guided biofilm therapy. A lot of bleeding, there was some suppuration, and in March of this year, there was no bleeding after the therapy at all. When we compare the pocketing from June to March, we can see that there was improvement in almost every location. Still needs some improvement. There is still some pocketing in some areas, and so we'll continue to treat her, but very, very much improved. This is an implant patient where the implant was placed in 2013, and this year she came back to us and said that there's been a lot of bleeding. We took this x-ray and saw that there was bone loss. So looking at her biofilm, this is what we saw. So here, this is a time lapse of her biofilm, and we can see amoeba running around. So amoebas are protozoan, parasite, and you can see how active they move very, very slowly, but you can see that they're very active, looking for food and looking to eat the white blood cells and other remnants in the mouth. So here we gave her a course of amoxicillin and metronidazole, did some guided biofilm therapy again, and as you can see, it's much improved. There were no visible amoeba anymore. Still a fairly high bacterial count, so we continue to do some treatment. We actually, in her case, gave her another round of antibiotics, and she's doing much better. So amoebas can certainly present in a dysbiotic biofilm, and they're considered commensals. They're not considered pathogenic, but I certainly wouldn't want them in my mouth. And we have also seen them when the bacteria when there isn't dysbiosis, so it's possible that they can pick it up from contaminated water or drinking contaminated water, or swimming in a lake, or somewhere where they manage to have amoeba in the water. Here's another parasite. This is a trichomonas. Unlike the amoeba, this is actually real-time recordings, so you can see them moving much faster than the amoeba. And just as frightening. Again, something that we don't want to have in our mouths. And if you're interested to read about oral parasites and disease severity, there's a number of papers that you can read. So several species of bacteria can actually internalize within the epithelial cells. So things like P. gingivalis, AA, T. forsythia, Fusobacterium nucleatum, Prevotella intermedia, they can all internalize into the epithelium, which means that it's essential that we use lasers to remove that diseased epithelium and to try and remove these bacteria when there is a severe infection. This is a case of Treponema denticola. The red indicates that the treponema have entered into the epithelium, and you can see that the study shows that it only takes 30 minutes for these wild type T. denticola to enter through the epithelium, so it can happen very quickly. But just because we use lasers doesn't mean that we have a perfect biofilm. This is a case where we treated them 6 months ago, and there's very little clinical signs of disease, minimal bleeding, no pocketing, but you can see a very dense biofilm with many, many spirochetes. So live microscopy will tell us when there is an oral dysbiosis. We can see that. We can tell if the patient's home care is sufficient, whether that be perhaps they're not compliant, or if they are compliant, whether we need to add additional home care techniques such as oral irrigators or tongue scrapers or some sort of mouth rinse. It tells us if our therapy is enough to cause a bacterial shift, whether we've reduced the bacterial load or the motility or the morphotype that's there. And it also allows us to decide when retreatment is necessary. If we see a really dysbiotic biofilm, should we be seeing them in 3 months, or is it 4 months? Or are they quite good and we can see them in 6 months again? So we can decide, for a case, whether peri-implant case or periodontal case, whether or not we treat them more frequently. And hopefully we can do that before there's clinical signs of mucositis or certainly of bone loss. So for optimal management of the oral microbiome for peri-implant disease, with implant health and mucositis, we need excellent oral hygiene. We want regular professional biofilm monitoring and removal. We have antimicrobial rinses at our disposal as well, things like ozone peroxide and so on. And then we can decide if we need to use antibiotics for parasitic infections and for implantitis, when it becomes more difficult, that's when we can use all of the therapies available to us, or we can additionally use laser therapies and surgery. And in future research, hopefully they'll find out more about the links between smoking and cardiovascular disease and other chronic inflammatory conditions. There will hopefully be better biomarkers that allow us to maybe pick things up earlier or decide when we should start laser therapies, the effects of different types of diets. And then hopefully there'll be other agents, whether symbiotic or antagonistic, which will allow us to reduce the different types of morphotypes that we see and reduce the overall bacterial load. So I hope you enjoyed that.